Okay, so hi everybody. It's great to have Dr. Kevin Elias with us today. Dr. Elias is joining us from Brigham and Women's Hospital here in the Boston area. He's the director of Gynecological Oncology, and he's an assistant professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School. So Dr. Elias received his bachelor's in history and in science at Harvard University, and then his MD at Vanderbilt University. And then he joined Brigham and Women's as a resident and a fellow, and then performed a postdoctoral stint in chemical engineering at Massachusetts Institute of Technology. And then since 2016, he's been a faculty member at Harvard Medical School in Obstetrics and Gynecology and Reproductive Biology. And he's now, as I mentioned earlier, assistant professor at Harvard Medical School. So it's great to have Dr. Elias with us today. He's an expert in ovarian cancer, and today he'll tell us about miRNAs as biomarkers for ovarian cancer screening and diagnosis. So welcome, Kevin. Thank you.
All right. Well, thank you very much again for the invitation to come speak. Apologies for not being able to have the video on, but the slides are probably more important than seeing my face. Are you able to see the slides okay?
Yeah. Okay.
Perfect. All right. So I'm going to talk about miRNAs as biomarkers for cancer screening and diagnosis. And this is going to be specifically focused on ovarian cancer, but the principles I'm talking about likely extend to several cancer types and even some non-malignant conditions. The only disclosure I have is that the Brigham and the Farber do have some IP related to this technology. It does not benefit me much personally, but the institutions have some investment in it. So modern cancer screening is a fragmented process. The issue right now is that the way screening essentially works is that you have one appointment and one screening type per cancer type. And so what ends up happening for the women that I see in my practice as a gynecologic oncologist is for their cervical, breast, and colon cancer screening, it's 3 different doctor's appointments for their pap smear, their mammogram, and the colonoscopy. It's 2 or 3 days off of work. They're very uncomfortable procedures. The cost per case identified is extremely high, and these are very resource intensive screening strategies. The issue that I run into most particularly in my practice is the fact that the 2 most common malignancies that I treat, ovarian and uterine cancer, have no screening tests. And so ultimately what we'd like to be able to do is to have, say, a blood test or some sort of other common assay, or be able to give people essentially a risk matrix where we could say your risk of these cancers is high and your risk of these cancers is low, and then really be able to tailor screening to the risk profile of the individual. Now I'm going to talk mostly about ovarian cancer, as I mentioned. So why do we focus on early detection for ovarian cancer? Well, ovarian cancer has the highest percentage of deaths per case of all the gynecologic malignancies, primarily due to the fact that it presents most of the time as an advanced stage disease. So the women I see in my practice, about 70% of the time will have disseminated disease through the abdominal cavity, stage 3C or 4. Typically involving all 4 quadrants in the abdomen, often requiring multiple upper abdominal and pelvic procedures in order to achieve cytoreduction. And unfortunately, outcomes for patients with advanced stage disease have not appreciably improved over the last 30 years. We've had some marginal improvements for patients with stage 3 and 4 disease, but the improvements really have been in stage 2 disease. And if we see people at stage 1 disease, patients with disease localized to the ovary or fallopian tube have a greater than 90% 5-year survival. So the difference between seeing someone with advanced stage disease versus seeing someone with stage 1 disease is really a difference in prognosis of a 25 to 30% chance of 5-year survival versus a 90% chance of 5-year survival. Now, of course, my patients ask me when they present, well, why is it so hard to make an early diagnostic test? And this is really a prevalence problem. So, we use low-dose CT scanning for smokers to screen for lung cancer. Well, that's because the prevalence of lung cancer among active smokers is a little bit less than 1 in 1,000. 1 in 1,000. Whereas for ovarian cancer, you're talking about a prevalence about 1 in 2,500. So the issue with screening for ovarian cancer is that even if you had a test with 90% specificity and 95% sensitivity, which we would consider to be a pretty good test for most clinical purposes, if you gave that to all women over 40 in the US, you'd be screening 186 million women per year. And you'd end up with almost 19 million false positive tests. So conventionally in the field of ovarian cancer screening, we set our specificity bar as 99.95%. And even that is giving you 2 false positives for every case. And so the problem in ovarian cancer has historically been a specificity issue more than a sensitivity one. So in my laboratory, the way that we've approached this is to go beyond the coding genome. So of course, most biomarkers that are used in clinical assays are proteins, but the protein portion of the genome is less than 3% of the genome. This being an RNA form, I imagine that most people are quite familiar with that. When we think about the non-coding RNAs, we of course divide them broadly into the small and long non-coding RNAs. Now within the small non-coding RNAs, microRNAs are one type of small non-coding RNA. And the reason that we've tended to focus on those are really for 3 reasons. The first is the fact that there's a relatively limited number of them, just slightly more than 2,000, whereas there's tens of thousands of long non-coding RNAs. The second reason is that they're quite conserved evolutionarily. So if you want to develop model systems, microRNAs actually work pretty well, even down to C. elegans, where long non-coding RNAs are actually not that well conserved evolutionarily. And the third thing is simply a practical thing. We have some idea of imputing function of microRNAs much more easily than the long non-coding RNAs, where function can be a little bit more obscure to determine, or at least more difficult. Now, as biomarkers, microRNAs are interesting because they get into bodily fluids. So now they don't all get into bodily fluids. It's only about 10% of microRNAs that get into bodily fluids, or at least into the bloodstream. And they can be packaged as either microvesicles or exosomes. They can be in apoptotic bodies. They can also be freely circulating, either bound to HDL or bound to chaperone proteins like argonaute. But the ability of these microRNAs to circulate is actually a sequence-determined phenomenon. There are redundant sequences in microRNAs with the capacity to circulate that are not found in microRNAs that don't circulate. And so even within the 2,500 or so microRNAs that have been identified in the human genome, there's only somewhere between 200 and 250 that actually reliably get into circulation. So the pool of biomarkers that you're looking at is relatively small when you're talking about RNA species. MicroRNAs also fit into the competing endogenous RNA hypothesis. And again, people may be familiar with this, but this is sort of the idea that different RNA species will compete with one another, particularly when it comes to regulating mRNAs. And so we think about microRNA response elements as much as we do target sequences. So this is, of course, how you can have multiple microRNAs regulating the same mRNA, or multiple mRNAs regulated by the same microRNA. But part of the idea here is that there's a finite microRNA pool, and then different RNA species are competing to bind that microRNA, whether it's the mRNA or link RNAs, either within the cell or, as we're interested in my lab, potentially within the circulating biofluids. And that if we think about endogenous RNA being an intracellular phenomenon, the pool of RNA in blood is several orders of magnitude greater than in the cell. So it's quite likely that there's some similar physiology happening within circulating RNA species. We tend to think of microRNAs as shorthand for cellular phenotypes. So again, there's more than 360,000 mRNAs in a single mammalian cell, regulated by a relatively small number of microRNAs. And so we tend to think of it as our shorthand for peering into the transcriptome of the cell. We can impute a lot of information based on a relatively small number of microRNAs to get a sense of what's happening intracellularly. And again, part of this is because microRNAs will often regulate several members of the same pathway. And so you might be able to get a sense of what's happening inside the cell simply by looking at the microRNAs circulating around the cell. Now, in my lab, we think about this as a data science problem because, of course, if you're mapping all the different RNA species relationships within a cell, you're going to get up with very complex networks, which you can start to collect through high throughput data collection like RNA sequencing. But really the goal from a clinical perspective is network reduction. So how do you take a highly multidimensional problem and shrink it down into a clinical question of interest? For instance, does this person have cancer or not? And that's where we've employed machine learning as our technique of choice. Now, again, this being a sort of an RNA focused group, I'll get pretty specific into the methods here. But the basic idea is that we're essentially triangulating what's happening in the cell. So if we know a few specific microRNAs, we can summarize some parts of the cellular identity and try to get a sense of the underlying genomic architecture of the cell. So we described this technique in an eLife paper a few years ago. And really, this is a methods paper where we're trying to say, if you wanted to apply machine learning to circulating microRNAs, of the dozens of machine learning techniques, what's the most robust way to do that? And which microRNAs should you actually look at? So the way we designed this study was we started with 180 patients drawn from 2 cohorts based at the Brigham, the pelvic mass protocol, the New England case control study, and then a prospective study that I had run called the Erasmus study. And we did small RNA sequencing from those samples. When we design diagnostic models, we tend to focus on microRNAs that have a essentially a negative value, or a value that's not 0. So in other words, we want a lower bound to our reference range. We get very concerned about microRNAs that have 0 values when we're trying to develop diagnostic tests, because you run into a technical issue. You don't know if your test just didn't work for that particular sample, or if your microRNA is truly absent in cases versus controls. So we randomized these samples into training and test sets. And then we went through essentially 33 different methods of how we might examine these. So first we had to decide how we actually wanted to select microRNAs of interest. So we did simple t-test significance corrected for false discovery. We did a correlation feature subset analysis to look at groups of microRNAs that were not correlated with each other, but that tended to select for the classification choice of interest. And then we went for microRNAs based on fold change from the sort of median microRNA value. Then each of those potential 3 ways of selecting variables, we put them through different types of machine learning models. So some of them are very familiar, I'm sure, to most people, like logistic regression and Bayesian networks. Some of them may be a little bit more exotic, like multi-layer perceptron and functional tree. And then we compared those models based on their sensitivity and specificity and tried to select what we thought was the best model as far as performance. And then we validated that on a testing set that had been held out from the original discovery. And then we went on and validated on the non-batch adjusted data, and then an independent sample set that had not been included in either the training or testing models. So this is a little bit maybe more for people who are familiar with ovarian cancer. We had a group of our controls included benign lesions as well as truly healthy controls. Our cancers were a mix of patients with truly early stage disease as well as advanced stage disease, trying to capture kind of the spectrum of patients as they might present in clinical practice. In general, these were not patients with overwhelming burdens of disease. The median CA125 being a common biomarker used for monitoring treatment response to ovarian cancer, the levels are relatively low, looking at about 100 per patient. Typically, patients with ovarian cancer will have CA125s in the several thousands. So as I said, we went through this univariate comparison to sort of initially divide either cancer cases from patients with either benign or non-invasive lesions, and then put it through a raw p-value and a false discovery rate to kind of come up with a top list of microRNAs. And as I mentioned, we had 3 different ways of grouping the variables to then build models. So, and these resulted in slightly different microRNAs that might be used for model building. There's some overlap among the 3 different variable selection methods. So you'll see, for instance, microRNA 320D appears in all 3 different types of selection filters, whereas microRNA 16.2 only appeared within the correlation feature subset selection. And then there's slightly different numbers of micros using these 3 different techniques. And then what we did is we went through those 11 different models, and we essentially did very large classification matrices, where we went through sample by sample and developed best models for each one. And then essentially rank them for how well they did sensitivity and specificity wise. And so for each model, for each case. And then we reported out the sensitivity and specificity for each of the models, for each of the variable techniques. And what we decided to move forward with was a neural network approach using a multi-layer perceptron. So the reason for that was that that had, again, these aren't necessarily statistically significant differences, but that had the highest sensitivity among the various models at specificity that was approximately similar to the other ones. So we decided we would explore that one further. And this is just showing the C statistic on these. So we had seem to have the best AUC there, particularly when we use the fold change method for grouping the variables and the neural network as the way of building the model. So again, this is just deciding, not the model, this is deciding of the ways to build models, which models do we think are the best for looking at circulating microRNAs. So how do these artificial neural networks work? Well, essentially you're including many different variables. You're assessing the relationships of the variables to one another through what are called neurons or hidden layers. And then you may have additional hidden layers where those neurons have relationships to each other. And ultimately the model will give an output. In this case, the output is a probability of cancer for that specimen. And like all machine learning techniques, the more the network sees, the neural network gets smarter as it goes along. The more variation it sees, the more precise the classification. So obviously that can be really complex for people, and sometimes people don't like the idea of what we call black box learning sometimes. So the best analogy I typically use is it's like looking at a night sky where the pattern of stars is seemingly quite random. There's really no significance of any one star in and of itself. If you look at a constellation, though, of stars, you can start to see a pattern that is identifiable. So we look at a constellation. The location of any single star is not so important. It's the relationship of the stars to one another as a pattern that you can see wherever you are in the world. And that's really what we're looking for with these neural networks. What are the relationship of these microRNAs to one another in higher dimensional space and as far as relative intensity? So we came up with a 14 microRNA neural network for distinguishing cases from controls. So again, from that initial 2,500 microRNAs that we've come up with in sequencing down to roughly 200 microRNAs that are well represented across more than half the samples at a minimum threshold of 10 transcripts per million, and then down to a 14 microRNA network that was most informative for creating a classification model. And there had been some batch adjustment in the initial selection. We went back and reanalyzed the data without any batch adjustment among the cohorts, and we found that the RC curves were quite similar. We compared this neural network approach to CA125, which again is the most commonly clinically used biomarker for ovarian cancer. We found that the marker outperformed CA125 in terms of just overall operating characteristics. Interestingly, if you look at the individual micros, there was no correlation whatsoever between any single microRNA and CA125. And this again is, I would say, consistent with a lot of what we know about micros, whereas single micros often don't have a lot of prognostic value. It's really sets of micros and the relative relationships to one another that might be clinically informative. And then we went to see, well, why was this better than the CA125? CA125 is a very common clinical biomarker. So where did it do better? In particular, the CA125 fell down when it came to non-serous cancers. Serous carcinomas are the most common type of ovarian cancer, but about 30 to 40% of ovarian cancers will be non-serous. So the network did a better job of not having false positives for non-serous cases. And it picked up slightly more, particularly of the early stage non-serous cases. It was also less likely to misclassify complex benign lesions. We also looked age-wise, how the marker did in the neural network. It was not sensitive to age. So whether we looked at premenopausal patients or postmenopausal patients, the performance was quite similar as far as the negative and positive predictive value of the test stratified that way, which is important because we know lots of biomarkers like CA125 change with the menstrual cycle and other reproductive factors. And the neural network did not seem to be related to that. Another example of things that change with age are DNA methylation. So any cancer test that relies on methylation as a marker, methylation changes correlate very strongly with age, and that can be a problem with DNA methylation-based models. Now, again, we were looking at sort of a case control population. So we wanted to look for an independent data set to see how this strategy would work on something more resembling a clinic population. So we used a publicly available data set from Keller and colleagues, which covered a dozen different conditions, including multiple different types of cancer, multiple different inflammatory conditions, and it had a small set of ovarian cancers within that sample. And what we found is that this was not a pan-cancer diagnostic. We were only picking out ovarian cancer cases quite specifically. We were not picking out other cancer types. So this was not something that would just say you have some type of cancer, we're not sure what. It really was specific for ovarian cancer. So applying this to sort of more of a population level, we picked out all the ovarian cancer cases from this group. And the negative predictive value was quite high. Now, again, this was 450 samples, again, but that's still a relatively small sample set. So what we're doing right now is we have a grant from Mass Life Sciences, and we're looking at 10,000 samples from the Mass General Brigham Biobank to really try to get a sense of population level performance of this type of approach. Now, it's all nice to use microRNA sequencing as a technique, but I don't think anyone's going to employ whole small RNA sequencing in their clinical practice. And so we wanted to validate, were these microRNAs that we picked out, was just a random set of microRNAs we trained a model on, or if we use a different platform for these microRNAs, would it work just as well? Hopefully a platform that might actually be able to get clinically approved. So we measure the same microRNAs using qPCR, and now we use an even larger sample set. So we measured 120 samples from the original series that we had excess RNA for. We added in a couple hundred more samples from these case control studies, including additional healthy controls. And we found that the C statistics were quite similar compared to what they had been on the sequencing data, suggesting that platform-wise, you could convert from sequencing to qPCR and retain the same microRNAs of interest and train a neural network based on the CT values. That worked fairly well. And then we wanted to, okay, without doing any model calibration, just apply it to a completely independent sample set. So we had 50 clinical samples that were sent from our collaborator in Poland. And we apply in a similar distribution of stages and histologies and grades. And we applied the qPCR signature directly to this Polish data set, sample set. And we found that, again, it's maybe slightly worse than it had been in our in-house set, but certainly for a first pass at doing this, not bad. Certainly a lot better than just random chance. So it made us think that likely this approach has some value. Again, the thing, of course, about neural networks is that training a neural network like this in just a few hundred samples is still relatively small. And hopefully, as we train them on thousands of samples, these AUCs will get even more robust.
Hey, Kevin, can I just interrupt?
Sure.
We're getting some questions about what you're normalizing to. So in your first experiment, you did the sequencing. What was the endogenous reference, or did you just normalize to average reads? And then with your PCR, did you have a sort of normalizing, was there a spike in or a commercialized control?
Yeah, those are great questions, because normalization is the bane of microRNA analysis. It's actually probably the most useful thing in the entire paper, I tell people, is the list of normalizers that we give. Because once we've sequenced several hundred microRNAs from a very broad cohort of patients, we actually, the 14 microRNAs, there's a set of 9 reference microRNAs that we identified as being fairly invariant across the cohort. So now, interestingly, when we converted from I sort of glossed over this, when we converted from the sequencing model to the qPCR-based model, the signature actually shrunk, because there are microRNAs that you can detect at low thresholds by sequencing that are useful for the sequencing model, but they're not expressed at high enough thresholds that you can pick them up reliably with PCR. So we actually reduced the model in the PCR one to just 7 microRNAs plus two normalizers. So in the paper, we give what those reference RNAs are. Just in other work, we've now sequenced more than 1,000 patients, and we found that those recommended reference microRNAs work pretty well. The problem with using some sort of global normalization technique is that you'll never reproduce it because it's only going to be internally consistent with your sample set. And so from a diagnostics point of view, we really want to identify microRNAs that we can find, fairly invariant to clinical condition, and that will be reproducible from platform to platform and sample to sample. Was there a second question, or was that both the same thing?
No, that was it. No.
Okay. Okay, so now that we've got some semblance of either a model or a technique for developing a model, the question is how to say, is this model potentially true? And so for that, we've turned to different types of orthogonal data. And the 4 questions that I asked to say, is this model potentially true, is to say, well, does it work for patients with truly early stage disease? Because it's very easy to build a classification model that can tell you that a patient with 5 liters of ascites and lung metastases has cancer versus the healthy woman running a 10K doesn't. So does it work for patients who are fairly asymptomatic, those with truly early stage disease? Can we build a model that can reproduce this, meaning a laboratory model? Does the biology match our understanding of the pathogenesis of the disease? And does it work equally well for high risk and low risk patients? So these were the 4 questions that we set forward to try to confirm our findings. So for early stage disease, we built a second cohort with 75 patients with truly early stage disease. These are patients with pelvic confined disease. Again, patients with stage 1 disease have a greater than 90% 5-year survival. Those with stage 2 disease have about a 75% 5-year survival. We filled it with a lot more healthy controls, a lot more benign masses, and we repeated the whole thing. We did small RNA sequencing. We started from scratch, and then we checked whether the micros we'd identified before in our signature, did they come up again in our second attempt at doing this? And we did. We found that many of the same micros were well represented in this early stage cancer versus control cohort. We then built a model just like before, and the performance characteristics were actually slightly better than we had in the papers, or quite similar at least. So suggesting that at least repeating the methodology on an independent sample set that was an early stage sample set, it seemed to work as well as it had originally. So at least to be able to reproduce the first finding. All right, then the second question is, how do you model this in a laboratory manner? So, one of the confusing things about stage is you can have a 30-centimeter mass that's limited to the ovary and you're a stage 1 patient, or you can have 1,000 1-millimeter tumors disseminated throughout your entire body and you're a stage 4 patient. So stage and volume of disease are not entirely well correlated. So were we just picking up patients with very large early stage cancers? So we developed a laboratory model of low volume disease where essentially, this is a xenograft model. So we're picking up human microRNAs in mouse blood. But with that kind of system, we can control exactly how many cancer cells are in the animal. And we can image them to make sure we have tumor engraftment and then do serial blood draws. We also gives us the opportunity to let each mouse be its own control. If you have a mouse that doesn't have cancer, and now you know exactly when it has exactly how many cancer cells, can you distinguish the mouse from when it had cancer from when it didn't? So we tried this on 3 different ovarian cancer cell lines, which are commonly used in the laboratory. These are all high-grade serous cell lines. We had also mice receiving vehicle. In this initial study, each mouse received 500,000 cells IP. And then we took blood draws at baseline before the injection at about a week and about a month afterwards. So what you see, these are luciferized cell lines. We can roughly see where the tumors have engrafted in the mice, and then use the same approach or a modification of the same approach to build a murine neural network using the circulating microRNAs in the mouse. Of course, with the mouse, you're using maybe 50 microliters of blood from the mouse to do this, as opposed to 0.5 milliliter from a human. But we essentially could make a network that looked quite similar. You have to modify the methodology a little bit because you're dealing with a smaller sample size. So you use a leave one out approach to do this. But then what we found was that we could, even in mice that didn't show up by IVUS imaging, but I didn't show up the luminescence. If we actually necropsied the mouse, pulled the cancers out, and then looked at them under chemoluminescence imaging, because these are luciferized cells, we could pick out tumors that were below the threshold of IVUS imaging. So you can see here, these are about 1 millimeter tumors that we're picking out that are there. They're not visible with the naked eye, but you can pick them out with a chemoluminescence enhanced technique. And then we were able to identify, were those actual mice-bearing tumors or not. So to test this, because obviously subjecting the model to the same lines that it was trained on is probably not the way to do it. We decided to use a fourth cancer cell line, which had not been used to train that murine model. And we decided to get a sense of the sensitivity of the model by doing log-fold tumor injection. So now we took 15 mice that didn't have cancer, 15 mice had cancer. The mice had different volumes of disease, as few as 50,000 cells up to 5 million cells. And then we followed the mice again out for a month. Then we randomized the mice by cage as far as which mice got placebo or got different types of levels of tumor. And we analyzed them in a blinded fashion. So because these are blinded, what you basically end up with is some mice in some cages have cancer and some mice in some cages don't, and they have different amounts of cancer. We didn't, obviously know the labels on these until after we did the analysis. But what we found is that essentially, if you applied that model, again, without any retraining, you just applied the model from the first 3 cancer cell lines to the fourth one, we were able to identify all the mice that were bearing tumor, regardless of tumor volume. Sensitivity was perfect. Specificity was not. It was pretty good. We had a few cases which still registered kind of high. But at least from a sensitivity point of view, which is really the purpose of this model system, it seems like we can pick up very low volume disease. So these are 50,000 cells in about 50 microliters of mouse serum. Now, what about biology? So most lethal ovarian cancers actually are ovarian in name only. If anyone familiar with the pathogenesis of ovarian cancer may have heard that in the last 15 years or so, we've reclassified most of these as fallopian tube cancers. We think that they mostly begin as intraepithelial carcinomas at the distal fallopian tube and then shed onto the ovary early in their pathogenesis. And that's where they really become tumors. The risk of this increases with lifetime ovulation. So patients who start menarche earlier or end later or have fewer pregnancies or later menopause are higher at risk for ovarian cancer. So to look at the biology, we did in situ hybridization for several of the microRNAs from the signature. So we looked at these stick lesions, these pre-invasive cancers. And we actually did ISH for different microRNAs that were in the signature. Obviously, in this case, we're looking for the ones that are overexpressed because the signature includes both upregulation and downregulation of microRNAs. We could see that these were clustering within the these intraepithelial carcinomas. We correlated these with protein biomarkers for neoplasia, so mutated p53, Ki67, which is a proliferation marker, and we looked at several of the microRNAs across either intraepithelial carcinomas transitioning into stage 1 cancers, or stage 1 confined cancers. And we found, again, that the microRNAs that we were interested in were expressed in the lesions, but not in the adjacent normal epithelium. So what that tells us is that we think that the microRNAs, or at least most of them, are coming from tumor cells. We don't think this is, say, some sort of inflammatory reaction or secondary systemic phenomenon to a nascent tumor. We also looked at different cell lines. So we looked at immortalized fallopian tube cell lines in the lab versus various ovarian cancer cell lines. And we found, based on microRNA expression, they clustered separately. If you use the microRNAs from the signature just on cell lines, you can use that to distinguish benign cell lines from cancer cell lines. We tried to get in the biology a little bit. We found that most of these microRNAs are targeting EMT, which is interesting. It was pretty consistent whether we looked at BRCA wild type or BRCA mutated lines. some differences by degree, but in general, we think that EMT is the process that's required for these tumors to progress from being restricted to the fallopian tube to then disseminating in the abdominal cavity. So it would make sense if the microRNAs might be targeting those transcription factors. And then the question became, all right, well, but does it work for both high risk and low risk patients? How useful of a test will this be? So as I mentioned, since we published the original paper, we've now sequenced about 1,000. I think the slide's even a little bit old, but it's about 1,000 samples. We've sampled specimens from 3 continents at this point. And we have a pretty good mix of BRCA positive and BRCA either negative or agnostic patients, pretty good mix of benign or control masses versus malignant. So we're getting a lot more information going into the artificial neural network now. What that's allowed us to do is to trim down the signature some, so to really more of an 8 microRNA signature. And if we apply this to BRCA patients, we start thinking about, well, we know that the lifetime risk for BRCA carriers by age 70, between 40 and 70, is about 26%. Their true lifetime risk is about 40%. But if we focus on the age between 45 and 70, when you probably would have the highest quality adjusted life years gained by having a screening test, really it's about a 1% per year risk for BRCA1 carriers. So we thought, well, what if we tested just that population? And so if you simulate that performance, really what you'd end up with is about, if you were screening 1,000 women from the ages of 40 to 75, about 10 of them are going to have ovarian cancer at any given time. If you had a test with that sensitivity and specificity that I just mentioned, you're going to be picking out about 1 case of cancer for about every 2 false positives, which again is about the level that we had set at the beginning of what we were thinking would be an acceptable performance characteristic. Again, particularly now you're talking about a high-risk population. So these are usually women who are going to be considering prophylactic surgery anyway to remove their tubes and ovaries to prevent cancer. So if you're saying, well, if 1,000 women who you might be recommending surgery to, maybe you can break that down to just 26 of them actually needing surgery. And if you do that, you'll pick up 90% of the cancers. It's at least a promising approach on paper. We also had some longitudinal samples from our colleague in Poland, where we were able to look at patients who had blood drawn years prior to a diagnosis of cancer. And we could find that if you essentially repeated your test on patients as their cancer diagnosis approached, that the probability of cancer predicted by the neural network algorithm increases as the time to diagnosis decreases, right? So there does seem to be some dose-dependent effect here. So this is something else that we're trying to understand right now, is if we put people into a modeling or a surveillance protocol, yes, having a point estimate of cancer is useful, but maybe what we really care about is the delta, which is from 1 year to the next, is their risk profile increasing such that we would recommend surgical intervention sooner. The other thing is, can we interpret microRNAs in view of BRCA mutational status? Because all the original work was agnostic to any clinical information about the patient. So what we think is, if you test the patient for BRCA deficiency, if it's unlikely that they have BRCA deficiency, then the prevalence is the population prevalence, which is about 1 in 2,500. So if you apply the model to just that population, we have a model that has a relatively high negative predictive value with a fairly low positive predictive value. So you're only going to pick up about half the cancers, although again, for a low risk population, that may be fine. But very, very few patients that are going to be, as far as told they don't have cancer, that actually do in absolute numbers. If we go to the high-risk population, then we're thinking about modeling it on a 1% prevalence, and there our concerns are different. We're mostly concerned about sensitivity. We want to pick up most cancers in the high-risk population. We're willing to sacrifice a little bit on the specificity because, again, it's a high-risk population. That right now we recommend 100% of them have risk-reducing surgery. So there, we think we can get the positive predictive value up to more like about 1/3, which is about where we would want it, with only a slight loss in the negative predictive value. So likely the neural network approach, it's really 2 tests for 2 different populations. So where are we going with all of this? This is not quite ready for clinical prime time, but it seems to be encouraging. We have a clinical trial going on right now at Brigham Women's and Dana-Farber called the MIDI study. So it's the microRNA detection study, and this is for high-risk women. So those are women who either have a known genetic mutation like BRCA or Lynch syndrome mutation, or BRCA-like mutation like BRIP1, who have either come to us through the genetics clinic or the Gynecology or breast cancer clinics, or they have a family history. So maybe they've tested negative for BRCA, but they have a family history concerning enough that they still meet clinical criteria for hereditary breast and ovarian cancer syndrome. And so we've put these women into a 6-month blood collection protocol. This is an observational study. And we know statistically that about 5% of these women will be diagnosed with cancer when they undergo risk-reducing surgery eventually, or they'll be diagnosed with cancer in the interim despite being on a surveillance protocol. And so our goal is to enroll 500 women and follow them for 5 years. We've enrolled, it says 77 patients. I think it's 77 patients to date, but we have now collected about 200 blood samples from those patients. This is a collaboration between my laboratory, Dipanjan Chowdhury's laboratory at the Farber, and Judy Garber, who runs our genetics group at the Farber. I will say the other thing about the MIDI study is it's open nationwide because we have mobile phlebotomy available now. So even patients who are not local to Boston can still participate. We're also interested, of course, in applying this methodology to other cancer types. So based on how well you can multiplex microRNAs for high throughput analysis, we think we can measure maybe up to 10 cancer types in one sample. I don't know that all of these cancers would be amenable to microRNA screening. I don't think it's a panacea for cancer screening, but certainly for cancers that have similar underlying risk factors. So for instance, patients at risk for ovarian cancer are also at risk for breast cancer. Patients at risk for colon cancer are also at risk for endometrial cancer. Men of patients who have BRCA are at risk for prostate cancer. So could we develop panels that might be useful for patients with competing risk? Because we can tune these models for different cancer types. So you could maybe simultaneously give a probability of ovary cancer as well as a probability of breast cancer from the same sample. And we can do this with about 200 microliters of blood. It's fairly high throughput as far as the actual quantification. We're doing that, as I said, as part of Mass Life Sciences, as a collaboration with AbCam. And so in these 10,000 microRNAs, or 10,000 samples we're looking at, we've got a custom panel now of 200 microRNAs. We have this high throughput probe-based approach for measuring the micros. And we're starting with women to look at 5 cancers simultaneously, looking at ovarian, endometrial, cervical, breast, and colon cancer, plus a large number of controls. And we've got some new postdocs in the lab looking at this from the bioinformatics side. Because this is the first time we'll be talking about not just case versus control, but a multiple case classifier, which becomes a more complex mathematical problem. The other thing we've been able to do is turn all this into a cloud computing. So if you don't want to send blood samples and somebody wanted to collaborate and they said, well, I'm happy to run this qPCR in my own lab and send you the data, we do have this done as a batch upload. So someone can just upload a .csv file to a web portal and it will it'll run the algorithm on that CSV file, and it'll give you a little PDF of each patient or each study sample and tell you the normalized expression of the microRNAs in that subset and the probability of cancer there. So this allows us to work with collaborators in other countries, particularly ones that might not be able to send us data directly, and they can see for themselves whether the model works on their data or not. Of course, ultimately, what we'd like to do is to have a system where somebody could just mail a blood sample in to a reference laboratory and run it on a high throughput robot like the one we have in the lab. And then the computing runs in the cloud and just gets beamed right back to the electronic medical record as a test result. The probability this person has cancer or not at this time, or hopefully in the future, not do they have cancer at this time, but do they have cancer now, or are they likely to develop cancer within the next, say, 2 to 3 years? So that we can help patients with not just point risk estimate, but also with planning interventional procedures. So I'm going to finish there. I'm sorry if I spoke a little bit fast. I was trying to make up for my delay in starting time. But wanted to thank the people who have been most involved in this work. Stephanie Chan was a Gynecology fellow in my laboratory. Dan Kramer, who runs our epidemiology group and has been instrumental in providing us with access to many samples. Dipanjan Chowdhury, who I mentioned is my erstwhile collaborator in this work. And then we work with a fantastic computer science group at the University of Łódź in Poland, led by Wojciech Fendler and Konrad Stawisky, who are MD, PhD bioinformaticians. And then, of course, everyone in my own lab, pictured down on the right. And I'll just mention that we are hiring postdocs. If anybody on the line is interested or knows people who are interested in this kind of work. Thank you.
Great, thank you very much, Kevin. That was fantastic. I of course invite you to come back and speak. Once your clinical trial has had a chance to read out. We'd be very interested in knowing how that works out. So we have some questions in the chat. I'm going to ask those while other people are thinking, and then if you'd like to ask a question, feel free to unmute yourself and ask, or just type it into the chat. But we have a question from Demetrius Spensos, who asks, do the blood levels of the 14 or the 8 microRNAs correlate well with the microRNA levels in the primary tumor specimens at the time of debulking surgery?
Qualitatively, yes. It's a little bit hard to compare that quantitatively in the sense of what we tend to see when we look at the we've measured it mostly by in situ hybridization. So if we microdissect out the tumor specimens and we actually measure them by PCR compared to what we see in the blood, it's hard to make a direct correlation like that because you're dealing with very different volume of distributions. But what I can say is the microRNAs that are overexpressed in the signature are overexpressed in either tumor shells measured by PCR or histologically. I don't know that I would say that the ratios are necessarily the same, though. And now, one question, though, of course, is what do we make of the microRNAs that are downregulated? How does that work? Why would a cancer have lower microRNA expression? And again, I think that gets back to the competing endogenous RNA idea, which is it's likely that what you're seeing when you see a microRNA go down is it's probably an indirect representation of some other type of RNA species going up. Maybe it's a link RNA, maybe it's a circular RNA, it's something else that's sponging off that microRNA from the bloodstream. And again, that's a whole area that we haven't really explored, but I think would be really fascinating to look at.
Thanks. We have a question from Alice Rodriguez. She asks, could you use the microRNA panel for cancer recurrence or cancer remission? I guess predictions of whether somebody's going to come back and get cancer.
Yeah, so we have started to look at microRNAs as a prognostic biomarker. Now, again, it's likely a different signature if you're asking a different question. So the question of whether or not somebody who's already had cancer is going to get cancer again, virtually all these patients will recur at some point. So you may be able to monitor them using the microRNAs. That's an interesting question. The only sort of, I guess, counterpoint to that is the fact that earlier diagnosis of recurrence has not been shown to improve survival in this disease, unfortunately, unlike early diagnosis in the primary setting. Now, using the same approach from a prognostic perspective, so in other words, could you use the microRNAs to predict who might respond to one therapy or another? Maybe. And again, we've done some small studies looking at that. We've proposed some projects to some of the drug manufacturers to say we think we might be able to do that, because there do seem to be some relationships between the microRNA patterns we see and the genomic architectures of the tumors. So maybe we can help predict which patients might respond better to which therapies. But that's something that again, is an area of exploration.
Great. We have a question from Jan Heng. She asks, she says, excellent talk, Kevin. Did your team explore including clinical characteristics when building the models?
So the models are built agnostic to clinical information, and that is actually adding clinical information in is the active area that we're working on now. So we have, we're now putting metadata into the models. So in other words, if we considered age or we considered family history or menopausal status, you would think that the models would get smarter, although we don't know. So in the 10,000 samples we're looking at from the Partners Biobank, the MGB Biobank, we'll have that metadata in, and we'll see if that improves model performance. Yeah, the process of annotating 10,000 samples, though, is in and of itself quite an undertaking.
Great, thanks. I think our last question comes from Sudeshna Fish. He or she asks, does the mere presence of a specific microRNA in the signature suggest anything, or is it more the broad combination, like up and down, high and low, and their concurrence that signifies the disease state?
So any single microRNA, I don't think adds that much information. I think you need, in general, at least 3 or 4 microRNAs in the relationships to one another to make any kind of clinical judgment, because there's so many factors that can influence any individual microRNA. Now, there are exceptions to that. I mean, there are certainly microRNAs that have been, for instance, in testicular cancer, that have been shown to be very, very specific. But for the most part, I think it's the set of microRNAs. It's not just whether they're up or down. It's, I mean, there is a degree of the extent to which they're up or down is important. It's not just directionality. But I do think it's important when thinking about microRNAs, and this is, I get phone calls all the time from people and they say, I tried to use microRNAs to answer my clinical question, it didn't work. You know, why can't I find a micro that's going to work? And I said, well, they're not like proteins. There's not like a high and a low. They're responding to the transcriptome of the cell. So really you need a set of them, I think, to really understand what's going on. And I get skeptical whenever I read papers that tell me they've identified some magic micro which will answer all their clinical questions.
All right, I think we're going to end it there. So thank you very much, Kevin. It was fantastic, very thought-provoking, and hopefully it will one day find its way into clinical practice and be for helping ovarian cancer patients down the road. So thanks to all of you for listening. Thanks for your questions. Kevin, if you can just stay on, I just want to ask you about the recording. So we'll see everybody at our next event, which is next week. All the best, everybody. Bye-bye.
All right, thank you so much.